even as we live here, let us go and encourage the citizens out there to register as voters. With those few remarks, welcome once again, and thank you very much.
We're trying to catch up on time, and so without much ado, because we've had some discussions, I'd like to call to the podium Mr. Kibuga Kareithi to say a word as chair of JHL. Thank you.
Thank you very much, Josephine. I'm not sure I was in the program, but since she has called me up, I will say a few words as to the history of this group. Where did this group come from? And I was explaining to the CS and the High Commissioner that the idea of bringing healthcare into NCCK is both in our 2060 vision as a concept, but it became more than a concept when I brought the then GS to India, to Chennai, and we visited Dr. Reddy, who was the chairman of Apollo Hospitals, and agreed with him how to move forward on this vision. As you know, we brought in Indian consultants who gave us the thinking, and now we have a CEO, and we are bringing up the staff to become very much a copycat of India. There's nothing wrong with adopting technology. There's nothing wrong with adopting the best model. In fact, for the next 20 years, as we finish Vision 2030 and continue from there, most of what we'll do is adoption. Adoption of something that's already been done elsewhere. And so, as chair of the board, I'd like to acknowledge Bishop Kadi, who is also here with us. Do I see anyone else from the board? I think only the GS is with me today. To say thank you so much for this, Josephine. It was an incredible day. The Cabinet Secretary repeated our philosophy and strategy himself. And so I'd like to commend that strategy and that philosophy to those who are here as he comes to speak with us, so that we know that this is about technology. It's about taking the model of affordability coupled with access to bring outcomes, clinical outcomes, that are at or better than India to Kenya. That's what we're doing. Thank you very much, Joseph.
At this stage, I'm going to call on one NCD survivor. We have two. I'll only call on one. I'd like to call on Stephen Ogwell to come for just 1 minute, speak with us about young people and the battle against NCDs. I'd like him to be very fast on his feet. Stephen is a young person. We've talked about prevention above all else, and it must start with young people. Stephen, kindly speak to us.
Thank you very much, Dr. Josephine. All protocols observed. Speaking to you today, I have a very important task to deliver that I've been sent by the millions of young people that are represented under the NCCK, that the church gets to meet every day and every week. And these young people have given me 3 key messages that I needed to present, and then one daunting task that I hope I'll deliver for them as I finish my submission. But before that, briefly, I'm also living with non-communicable diseases myself, and been at this for the past 10 years already, living with non-communicable diseases. But it's because I got people very close to me who understood what these diseases are and how to prevent them. And they educated my parents and my family, and they were able to nudge me back to the healthy state that I am today, talking to you about what the young people of NCCK have sent me to present to them today. And without much further detail, before I go into the 3 talking points, I'd like us to turn to page 24 of this program. And when you look at the strategy document, you realize that This is one of the very first strategic documents that I've seen in the NCD space that specifically gives young people precedence and gives young people a responsibility in delivering of that strategic document. And so before I move on, I'd really want to thank really from the bottom of our hearts and representing all the millions of young people that for the first time we have seen in a strategy for non-communicable diseases that young people have been put as a key focus in implementing and realizing the strategy. Now, finally, as I move into the 3 key points that I was sent here to deliver from the young people of the church, and one is that we want young people to be actively engaged. We want young people to be not only involved in the development of these documents and the development of the strategy, but also be involved very actively in the implementation of these strategies, and even more importantly, in the monitoring and evaluation processes of this strategy. As evidence would show that young people, when given opportunities, we have been able to deliver. We have been able to create programs and implement on them together with development partners to be able to create impact, and we are hoping that we will also be very part and parcel of implementing this program. The next part, and this has, I loved it when Dr. Amit talked about it, is the implementation of technology when it comes to the health space. And young people, we are the ones leading that conversation on health tech. We are the ones who have really pioneered in developing some of the technologies that are currently being used by hospitals and health centers to be able to deliver information even up to the last mile communities on what these diseases are, how to contact relevant service providers, and many other components. And we'd like NCCK to really bring us on board, to really tap on this skill and technology and make us part of the development of these technologies that will then ensure that we move into the future of healthcare. And lastly, we want, especially from the ministry, we really would request as young people, if we'd have a help desk, if we'd have a center at the ministry and personnel that really is in charge of non-communicable diseases and young people, to be very specific, so that we are able to coordinate our activities, we are able to coordinate our movement with this help desk to ensure that we are able to then get deliveries and we are able to contribute actively into the implementation and realization of this strategy and even the national strategy on NCDs. Now, the final task was the hard one, and I'm a bit shaking now, but this final thing was I wanted to really invite Mr. CS to come in front of, on the podium, to stand with me on the stage and to have the hand on the chest as a confirmation that he is with us young people in this agenda for non-communicable diseases. Kindly. Yeah, so 3 things. One is really getting us a help desk, someone at the ministry, a young person who can be able to connect directly when it comes to non-communicable diseases. And 2 is solidify. I know, but he's not young. Yes, that is 1. And 2, we really want the information on non-communicable diseases to be more simplified and to be more available down to the health centers, because currently what we have is very hard to, first of all, it's very hard to get this information, but secondly, when you get it, it has big medical jargons like incidence and prevalence and mortality, and these are not common language to us as young people. So we want this information, go a step ahead and also really get this simplified so that we are able to access and engage with this information. And so finally, now that we've stood, we can stand. Tell me exactly what you want me to do. So the instruction is very simple, really. You're going to take this hand of yours, that other one, and put it across your chest. And you're going to stand like... My hand? Yes, your hand on your chest, like that. But my heart is on this side. No, not on your heart, just on your chest. Yes. Thank you very much. So a moment of silence for everyone in the ceiling of this commitment by the ministry. Thank you very much, and that would be it from young people.
Thank you very much. There's nothing like having a young person amongst us. Thank you so much, Stephen. We need to move forward very quickly. After that commitment to young people, I'd like to invite one of our seniors, Lewis Nguyai, who is the chairman of NHIF, to come and speak with us on affordability, particularly on NCDs. Welcome, Chairman.
Can you hear me? It's clear enough? The CS for the Ministry of Health, Dr. Mutai Kagwe, for now. For today. And all the other doctors. The NCCK fraternity, starting with Chris Kinyanjui and Bishop Vice Chair, the chairman of Jumia, Kibi Karidi, all guests from whichever sector, including Safaricom, Ministry of Health. Mine will be a very short discussion. An introduction. As you have heard, NHIF is part and parcel of the relationship with Jumia, but more so part and parcel of the initiative to support UHC. The government has actually prioritized UHC as one of the 4 priority agendas, and NHIF has been identified as the key flagship to ensure that every Kenyan, and I think it's important to define what universal health coverage is, that every Kenyan can access health care without suffering financial hardship. Now, that is just one aspect as far as NHIF is concerned, but the ministry now ensures more that every Kenyan does have access to quality and affordable health care. For us to do that, we had to go through implementation of legal and regulatory reforms to ensure that we are sustainable through a financing mechanism that has a robust and beneficiary identification and registration. NHIF was identified as a vehicle to carry out the financing of universal health coverage, and the Cabinet Secretary for Health appointed the Health Financing Reform Experts Panels that identified certain issues of reforms that are taking us on that journey. There are 4 of them. One of them is organizational transformation. We have to reform NHIF so that it has the funds, so it has to be a lean, effective organization which is responsive to beneficiary needs. And I thank the ministry for appointing a task force that is in Naivasha as we speak at present. And as we had discussed CS, I think it is important that you remind them that they should have finished this exercise by the 31st of January, they are currently working on an organizational structure that will not burden the fund and at the same time offer quality services to the beneficiaries. The second one has been discussed a lot by the chair and by Kevin and by quite a number of people, and it is digital transformation. We have started the journey in digital transformation, and we are now 100% digitally registering all our members, and we are 100% on the electronic claim management platform. That happened on the 23rd of July last year, which basically means nobody can access healthcare without going through the digital registration process, and that will then open a window of so many other benefits that will ensure that the right person is being treated, the right diagnosis is there, the data is being collected, there's one-stop medical health records, and as I told the CS, we have started that journey. And as you're aware, and you've mentioned it in the boardroom, it first, not the abbreviation, we are moving from National Hospital Insurance Fund to be now known as a National Health Insurance Fund, which key focus will be focusing on primary care, preventive care, and promotive care. And that's one of the items that I think we need to start building a discussion on, so that before, it's better to prevent than to treat. But also the change of name now allows us to get into contracts with not only hospitals, but with what we are calling healthcare providers, and those healthcare providers can now be individual practitioners, standalone laboratories, diagnostic services, but it also incorporates now technology, where we can now talk about contracts with telemedicine, contracts with technology providers, etc. The third element, I'm just highlighting a few. The third issue is that within the Act, we are now using what we call a Centralized Healthcare Provider Management System, CHPMS, and it will be mandatory for all empaneled providers to use that to manage claims, process payments, and provide data collection. Therefore, in this, the Unified Claims Process System will enhance efficiency of claims processing, but it will also be now a source of data on health services, and particularly for the ministry, artificial intelligence and issues that need to be looked in terms of analytics to be able to provide better strategic solutions as far as healthcare is concerned. The fourth element in the 5 is that the strategic benefits design has seen us now have to review, harmonize, and standard the benefits package across all contracted providers. This in line will mean that we will now be having what we have comprehensive benefits, so that Jumuiya and all other, and I think we've signed with the majority of the faith-based institutions, will be able to provide free healthcare benefits to the members. And in particular here in this area, as Kinyanjui told us, is that most of the people who come here cannot afford. We would want to partner very seriously in ensuring that the contracts that we are doing will make sure that those benefits are affordable, are available, and at the fairest price. With that, we have had to halt our contracting process so that we can further engage with you to address the issues that you have, but also align with the new amended Act, so that we can be able to provide the best services. In this context, I would want to say the reason that we are here on NCDs, the cardiovascular cancers, chronic respiratory diabetes, they are the world's largest killers. We do have very specific packages for each of them. And the majority of them now are included in outpatient management treatment. So you can come for an MRI, a CT scan, you can get medication, you can be able to have renal dialysis using your NHIF card. And as such, we feel that it is important, as the young gentleman has said, for us to now focus on partnering in how we can identify the sick. And one of the things that I think we need to really work on is NJEMA, NHF, Ministry of Health, carrying out medical camps so that we can really find where these patients are. One of the other exercises, because I know Professor is coming, we had a look at your paper that you had written to the President, and we would want to engage with the COG. Unfortunately, the paper, by the time the President, or you were writing it, the President had already accepted to the act. And so, I think all is not lost. The COG now has 2 seats. It's the only organization that has 2 seats in the board of NHIF. So the voice of the counties and in the devolution area does really have a representation, and you have the mandate and the powers to give the direction. But further to that, Prof, we will also make sure that very, very soon we'll have a stakeholders discussion. And as we implement the regulations, which, thank you again, you have already appointed a task force and given them a deadline of January 28th to ensure that the regulations are in place. And when I was engaging Parliament yesterday, they said we have to provide it to them by the 28th of February, because Parliament opens on the closes on the 20th of March. So it is fast tracking to make sure, and it has prioritized CS. So we are already in the agenda that between 28th of February and 20th of March, we will have the regulations. The High Commissioner of India, and Kibi has talked about it. I think even as we talk about telemedicine, and we have a big revenue hole, and one of the papers that we are writing is we still spend too much money taking patients to India. And one of the things we would want to partner again with Jumia is how can we now get capacity in Kenya from a technological perspective, from an equipment perspective, but more so from a human resource perspective, particularly as far as medical expertise and biomedical expertise is concerned. So I believe that we're in the right direction. I want to thank you once again for this AFIA NJEMA initiative. We are here to partner with you, and will continue to partner with you to ensure that every Kenyan remains healthy. Thank you very much.
Thank you very much for sharing with us the progress at NHIF. I think, CS, you're delighted that all this is taking place during the time you are in office as minister. It's a very, very large achievement. We must move forward with the program. We want to thank NHIF for all the services that they're making available to us. And at this time, I want us to focus on the virtual platform. We are joined by the governor of Kisumu County, Professor Anyang' Nyong'o, And he's going to greet us and respond to some of the concerns that have been addressed today. Perhaps tell us about the Marwa insurance scheme. If we're able, can we raise Professor Nyong'o? No. All right. CS Professor Nyong'o has been with us on the virtual platform together with Professor Kama Rogo. Professor Nyong'o wanted to share his personal story and also share his insights in a model or pilot health insurance scheme called Marwa Health Insurance. It's a congregational type pooled funding scheme, but at community level. I do hope he'll be able to come back perhaps before we go so that he sees us complete. But if not, at this point in the program, acknowledging all protocols, I want to hand the microphone over to the General Secretary so that he can assist me to launch, together with us all, the AFIA NJEMA strategy. Thank you very much, GS.
Thank you very much. CS, Ministry of Health, Senator Kagwe, our Vice Chair, Dr. Bishop Okinda, our Chair of the Board of JHL, Kibi, I call him Doctor today, the Chair of NJEMA, Honorable Nguyai, our Chair of FSC, several chairs and heads of churches that are here, heads of organizations, many development partners that we have from WHO, our partners in Safaricom, in World Bank, and the academia. We have several of them that are here, and the NGOs that we have, some of them that we had on board, the CEO of Rotary Family Health Days, who was joining us from the US, and Sheldon Paddy, who is the global initiative from South Africa. Our other organizations like CHAC, Dr. Mwenda, MEDS, Dr. Nandama, and especially our church leaders, Bishop Dr. Okinda, who is here, the presiding clerk of Methodist, of Friends Church, Andre Mukwanja, Reverend Letin from RCA, the moderator, Canon Rosemary, Bishop Magomere from Church of God, and Dr. Alphonse Kanga. And I can go on. I have a very long list here, and I wish I could mention all of you by name. Bwana asifiwe. God is good, and all the time. We are very delighted to host our chief guest, the CS here, to launch this program. When COVID happened, Canon Rosemary and I, and a few other church leaders and other religious leaders were appointed by the CS Health and CS Interior to guide the country during this period of COVID. What we realized is that we had a very weak link. People among us who are living with NCDs, and they were very exposed to the COVID. When they get COVID, it was very hard for them to recover. So we were very concerned as we work towards the reopening of places of worship. What are we going to do with all these who are already having NCDs? And we started a conversation asking, what do we do with this group of people? And that is when we started this discussion, and we took this discussion and to our chair here of FEC, Richard Kiplagat, and we started discussing. And we came up with an idea that we get an expert, and that's how we got Dr. Ojambo, so that we understand. Because for us as preachers, we know the eternal life path, but the other part of life on earth, they are also experts of how we can live better lives, CS. So she came up with a strategy, which we took to our board, and I'm happy one of our board members here, Bishop Kathy, is with us today. Welcome. So we adopted it, that we need to have a strategy that is all-encompassing. But talking to the chair of JHL, Kibi, this was actually the idea of us coming into the health sector and discussing it. So in our 100 years of history as the council, our churches opened up the first churches, the first health centers that have served this country. And therefore, this is just a continuation. As new challenges come, we open a new chapter of how to handle them. So we are very happy to work with our churches. We have many churches across the country who run small health facilities that provide health. But we want to bring now a message on especially two issues. One is awareness. We have realized even during this period of COVID that someone goes with COVID to the hospital, but then they discover they have cancer or they have diabetes, and that aggravates their situation. So we would like to use our pulpits and to use all the other forums that we have to pass the message of awareness for people of Kenya and the people of our churches to understand what are NCDs, what are these diseases, why are they killing more and more people in such an exponential growth, as Dr. Marie was saying. The graph is not flat. The graph is not even having a small gradient. It's actually a dramatic rise of the number of people. And we see this as a major concern. Apart from awareness, there are also issues of advocacy. We would like to be the voice of the voiceless. As you know, NCCK has been the voice of the people, so that the concerns that people have, those who cannot speak for themselves, how we can bring on board the big pharmaceutical companies like Novartis here. How can they bring medicine that is more affordable by the general population? When it comes to issues of access, bring an NHIF on board. How can they create packages so that if a person has kidney problems, that they can go to any hospital, private or mission or government, and access that service. And CS, I'm very happy to hear that when a patient is sick, they want health care. And it doesn't matter whether it's a private hospital or a public hospital. We need to get that to be there. We'll be having discussions with the Council of Governors because we know also the state of our county hospitals. So that then we raise the standards and so that there's medicine and there's healthcare providers to take care of our people. So awareness and advocacy are going to be very critical to us. And therefore, I am very happy to be part and parcel of this historic moment as we focus on the NCDs. Our chief guest, we are still fighting COVID, and a lot of people have spent a lot of money on COVID. And therefore, it will be very important for us to see how we create safety nets around the whole issue of Medicare. So we'll be working with the NHIF to see how can every Kenyan be able to access healthcare using an NHIF card. I know the government of Kenya has been promising and has promised universal healthcare, meaning everybody has access. But that's a promise. We need now to bring our feet on the ground so that we can work together, because it is not the responsibility of government alone to provide health care. But it is also not the responsibility of the public to pay, because NCDs are so expensive, nobody can afford it. There is need for insurance companies, and the public insurance is NHIF to push this agenda, so that as we cover the indigents, those who are poor, but more so, we look forward at how can we make sure that those who cannot pay, we help them. And those who can pay, they are prepared, they are facilitated, they are made aware that it is important for them to have a healthcare card. When most of our pastors, Bishop Kadhi, go to the village, a mother will go and catch a chicken. I know from peace, when you are seen, people ask you for money. But when pastors are seen, they are given money and they are given a chicken. Yes? Namayai. And there is obviously a meal around it. If you count the cost of that meal, it's more than 500 shillings. And under the NHIF, it's only 500 shillings to cover an entire household. So we want the pastor, even as we eat the chicken, canon, as we eat the chicken in the family, we talk to them so that because they have another chicken, they can sell another chicken and get a cover. We will work very closely with you. We'll work very closely with the Ministry of Interior, the chiefs and the sub-chiefs, and the Nyumba Kumi, so that we see nobody is left behind, whether they are boda bodas, mama mbogas, or just housewives, so that we bring everybody on board, including houses that are headed by children, because we have a number of them. CS, I don't want to speak much, but just to say that we are so happy to be part and parcel of this journey. We would like in every congregation, just like we are doing with COVID, we bring the health officials to come and vaccinate in our places of worship. We would like to hold medical camps in partnership with the health facilities and other providers to do screening, so that our people don't know that they are in stage 4 of cancer when they are already so sick that even if they went to India, they are not going to get Medicare. People to know early, and then they seek early treatment. We are also going to work so that once you have been diagnosed with it, you get psychological support, psychosocial support, we pray for you, and we make sure that we connect you with a facility that can give you high quality of care. And that is why we are all here gathered here, to all work together. We cannot leave this responsibility only to the CS. You know, the CS during COVID, he kept telling us that anybody can get it. I wish you can tell these people that everybody can get NCDs. In that language, they seem to understand. I've had it with young boys in primary school, and I'm sure if they hear that message, then we will be prepared enough to be able to tackle NCDs. With those few remarks, I'm very excited. Let's be upstanding and welcome the CS to address us. Yes, I'm advised to hand him over the AFIA NJEMA program, which is about to launch. So, CS.
Please sit down.
Yes, please sit down. So, this is the AFIA NJEMA program, and we'll be happy to hand it over to you. Yes, thank you very much. Welcome.
Thank you very much, Canon, for your kind words. And also, let me start by congratulating you on the launch and the thought of this strategic document. I recognize the personalities who are here, but I was told that none other than the diplomats, such as my sister, Dr. Josephine, that once people have been recognized by one person, it is no longer necessary to recognize them again. So I recognize all of you, ladies and gentlemen, wakubwa na wale wengine wako hapa. First and foremost, let me say how pleased I am to be here, because this is a really special occasion and a special day on which we bring together stakeholders and in a policy discussion on non-communicable diseases and launch of the AFIA NJEMA program. And allow me to begin by commending the National Council of Churches of Kenya for convening this wide representation of partners, which is a clear indication of the momentum and interest that prevention and control of non-communicable diseases is generating in the country. The stakeholder meeting is indeed timely, since the incidences and mortality from non-communicable diseases is rapidly rising, and combined with the prevalence of infectious diseases, continues to put a double strain on our healthcare system. NCDs, such as cardiovascular diseases, cancers, diabetes, chronic respiratory diseases, mental illness, epilepsy, sickle cell diseases, among others, represent a threat to human health and development. And, you know, I think it is Stephen, the young man who came here, who spoke to us about how we communicate with the masses regarding matters health. So we come here and talk about non-communicable diseases, NCDs. Let me tell you, wananchi out there don't know what you're talking about. All right? Kwa hivyo ni lazima tuanze kuzungumza na utofauti. Tukieleza wananchi NCD ni kitu gani. NCD sio kitu kikubwa sana. Ni ugonjwa wa kansa, ni ugonjwa wa sickle cell, ni ugonjwa wa lungs, sukari, mambo kama hayo. Hiyo pressure, ukiwa wewe unajifanya sana mambo mengi, unajipatia stress, unapata pressure. Hiyo pressure hata mtu akikaa karibu na wewe hawezi kupata. Hata mtu akikaa na wewe ukiwa na kansa mkae pamoja, huwezi kupata. Hiyo communicable ndio hiyo. Sio mambo ingine ya ajabu, ni kujua tu ya kwamba hii ni ugonjwa ambao hauwezi kupata kwa sababu mumeketi na yule mtu mwingine ama rafiki yako, non communicable. Lakini ukikaa na mtu ambaye ako na TB, wewe utapata hiyo TB. Ukikaa na mtu ambaye ako na COVID, you can get it and they can get it. But nonetheless, even the other one, even cancer, it still remains the same. And I'm glad to oblige you, Canon, to tell Kenyans that anybody can get cancer. Anybody. You can get it, and I can get it. Anybody can get it. But I think that the long and short of it is this. We will be given a lot of statistics, and you have got those statistics. 71% of people worldwide die as a result of non-communicable diseases. In our country, it is increasing to about 39% in the year 2020, up from 34% in 2015. So we are seeing an increase of the incidences of non-communicable diseases in the country. And this is not a good thing. What it means is that our families can easily be impoverished as a result of these diseases. Watu wanauza ng'ombe zao, wanauza shamba yao kwa sababu ya ugonjwa. Mtu akiwa na kansa, ukisikia mtu mmoja wa familia amepata kansa, ni kama kusema hiyo familia sasa itakuwa na shida ya pesa na mambo kama hayo. Vile vile ni kusema ya kwamba yule mtu ambaye amepata hiyo ugonjwa hawezi kwenda kazini. Kama hawezi kwenda kazini, hawezi kulipa school fees. Kama hawezi kulipa school fees, ni kusema mtoto hawezi kusoma. Kwa hivyo tukiangalia hali ya hiyo ugonjwa wa NCD, tunaona ya kwamba ni kitu ambacho ni lazima tukiwa serikali tuiangalie na tufanye bidii zaidi kuona ya kwamba watu hawatakuwa maskini kwa sababu ya NCDs. So ladies and gentlemen, let me just highlight one or two things as to make a long story very short, because it is a long story. First is the issue of reforms that we are carrying out in the Ministry of Health that can indeed be able to address some of those issues. I think the chair of NHIF has spoken to the issues that we are addressing, and the bill that was passed, now an act of parliament that was signed by the president, is one of the key pillars on which we are going to predicate the UHC program around the country. Now, the issue of affordability, affordable healthcare, is a crucial part of UHC. And we have just been exchanging ideas here with the team from this hospital about the need to match the amount of money that NHIF is paying and the amount of money that hospitals are charging, so that it is the same amount. This is important. Kwa sababu ukiambiwa sasa hapa MRI ni shilingi 9,000, alafu NHIF iwe inalipa shilingi 9,000 ama 8 ama 7. Ni kumaanisha ya kwamba yule mtu ambaye atakuja kutibiwa hapa ni lazima awe na shilingi 2,000. Kwa hivyo sisi hatutaki hiyo. Tukiwa kama serikali, vile tungetaka ni kama NHIF inalipa 6,000 na hospitali inataka 9,000, tuseme wacha NHIF ilipe 7,000 na nyinyi mlipishe 7,000. Mwananchi akija anatibiwa anaenda nyumbani bila kuulizwa chochote. That is what is called affordable health care. It's not magic. It's the way it ought to be, and it is the only way we can satisfy the parties and all stakeholders concerned. And that is why mimi nimeambiwa wale ambao wanazungumza, the team from Honorable Guyai's board and NHIF, they are currently engaged with faith-based and private sector players to reach a consensus about the various charges for the various diseases on various challenges that our people are experiencing. Therefore, the national health, and it's important for us now to remember, it is no longer called the National Hospital Insurance Fund. Let the word go forth from this time and place that it is now called the National Health, not hospital, not hospital. Please repeat after me. The National Health, the National Health Insurance Fund. And there's a reason why we changed the name to the National Health Insurance Fund. I think that has been elucidated very well by the chairman, and I need not repeat the logic behind this. But even as we partner, I think there are 4 key partners in the health sector in supply of UHC. The first one, of course, is the government of the Republic of Kenya. And we are investing substantially. This is the first time in our history when we have seen the private sector refer patients to the public sector. I was in Mombasa the other day, and I saw a patient who had been referred by the Aga Khan Hospital to come to the PGH hospital because PGH has equipment that private sector does not have, such as the cath labs that we have installed. And I think that Amit is a witness in this because he comes from the private sector. And we have worked very closely with them. So we have this growing partnership between the public sector and the private sector. And the government has to invest in health. It goes without saying. And one of the ways that you bring down the cost of the healthcare is investment in equipment that has previously not been available in the country. I witnessed, for example, in the same hospital, PGH, where in private hospitals, an endoscopy was something like 45 to 55,000 shillings. In PGH, because of the new equipment that we have brought, it is 6,000 shillings. So you can see the gap that existed there. And that if you had a colonoscopy issue, you had to go and pay 55,000 shillings. But now you can pay 6,000 shillings, which NHIF is going to pay in full. You can see the change. Is reforms that are going to have huge impact as far as our people are concerned. The faith-based organizations, I want to thank you. I want to thank you for the work that you continue to do in the area of the health sector. And the thought that you had, Mr. Chairman, to look at this whole thing of NCD through the faith-based organization, through NCCK, is one that is going to go very far in resolving and working together to resolve some of the problems that we have and challenges in the health sector. The private sector is the other partner that we have, who are also providing huge services to Kenyans. And I dare say that one of the reasons why Kenya is a tourist health destination has to do with the efficiency of our private sector people. But I also want to add one thing, that when we do our research, the big difference today between the private sector hospitals and the public sector hospitals is no longer equipment. It is not equipment anymore. It is a very simple thing called service. It is service. No more, no less. You walk into a private hospital and everybody is smiling at you and welcoming you. Now you're waiting for me to say something very clear. And then you walk into my hospitals, the government hospitals, and then you get all these things about a very dull face and so on. But I want to tell you, I want to promise Kenyans that the health sector in Kenya, the nurses, the doctors in the public sector are new people. I don't know whether it is because of COVID or what, but they have changed. You go to Pumwani tomorrow, where I hear women used to go to give birth and they are abused. They will even welcome the baby before the baby is born. So what I'm telling you is that we are changing and we are reforming and we are going to continue with the reforms so that the service offered in the private sector as in non-clinical issues will be equivalent to the same service that is offered elsewhere. Tuko pamoja hapo. So that's an issue that, but the final partner, as far as I'm concerned, in terms of provision of healthcare and the service of healthcare is the individual person. Individually. That the government, the private sector, the faith-based can only play a certain role. By the end of the day, health is personal. And we must look at it as such. And we must all ask ourselves as a people, as Kenyans, what is it that I can do individually so that my health is also taken care of? This is key to our success. We have discovered, for instance, during COVID-19, that hygiene and cleanliness is a key element of success in healthcare. We know that a lot of hospitals actually today are saying they don't have patients, no stomach problems, and many other problems that come as a result of being dirty. But now, because of the enhanced cleanliness in our society, we have seen a drop in incidences of certain diseases. And cleanliness is not a government responsibility. Cleanliness is first a personal responsibility. When we clean the streets because a certain accumulation of dirt is in the streets. But it is individuals who throw dirt in the streets. And therefore it must start with you not throwing dirt in the streets. And it is sometimes very discouraging when you are driving behind a very sleek BMW or a very sleek Mercedes. And as you are driving, you see just, banana peels being thrown off the car. Now, even a matatu doesn't do that. So imagine the image that you create. What's the point of that square of a Mercedes? And you are throwing banana peels out. It's a shame, really. We should be ashamed of ourselves for doing anything like that. When you stand outside your house and you just throw rubbish outside the house, you are infecting not just yourself, affecting and infecting even the neighbors. So I want to appeal to the faith-based organizations. I want to appeal to you, especially the clergy who are here. Please help us. Let us change people's attitude regarding hygiene. Let's just make sure that our people understand that there is a clear link between the way they behave and their own health. It is enlightened self-interest to stay clean. And I want to appeal to you that that fourth aspect of it becomes an issue to deal with. Ladies and gentlemen, I want to finalize my discussions by saying one other thing about the standards of healthcare. I've spoken to the issue of non-clinical issues, but I also want to attend to the issue of clinical issues. And I can tell you that as a government, we are determined to train as many people as possible. The health workers, we are not just talking about training doctors overseas. we are talking about a range of people within the health sector, lab technicians, nurses, and so on and so forth. So we are moving forward. We are looking at a number of things that are going to assist us in terms of the quality of our healthcare capital. Next month, we will be holding a curriculum conference that will address some of the issues that have been raised here in terms of the digital health sector. To what extent do we teach our own people, digital health? How are those people who are executing, giving service to the health sector, to what extent are they also trained in digital health? And you'll find that, sadly, at the moment, very little of it in our schools, very little of it is in colleges, even our universities have put aside some of those things. Yet the future belongs to those who will be digitally informed. The future belongs to those who will be able to communicate with the ones abroad who are digitally informed. That's where the world is going. We have two choices. Either A, we will be in front of that equation, like we did with M-Pesa. Kenya was the first country on earth to launch M-Pesa, money transfer via the phone. We can be the first country in many other things, including the first digital laboratories, digital theaters. When we plan our theaters, let us plan them with cameras and so on, so that we know that tomorrow, somebody in Egypt, somebody in India, somebody in the US can carry out an operation on you sitting in Nairobi, in a hospital in Nairobi, which means you don't need to go anywhere else. You can be treated here by experts. But the only way we can get this done is if our own people, we have a paradigm shift that takes us to that space, that takes us to a space where we have got hospitals that are paperless, and we think like that. So we need complete rethinking of how we are doing our hospitals, of how we are training our people, so that we are all thinking about the future. Yesterday is already gone. Today has only got a few hours. Our children and those of us who are alive will live in the future. Let's plan to do so in a more efficient manner. And I challenge you, NCCK, I challenge the private sector to lead in this process of ensuring that digital health is centralized and part of our thinking. Automatic thinking is how to be in the ICT sector. As you know, we are also in the process today of scaling up universal health care. And we are launching the AFIA NJEMA program that we are launching here today is a significant step in supporting that process. And again, we particularly applaud AFIA NJEMA's innovative spiritual outreach approach to drive the wellness agenda through specific church-led interventions, as well as commitment to support resource mobilization. I wish also to recognize and appreciate the important role played by NCCK and other religious organizations in not just improving the lives through the hospitals, but also the prevention aspects that you have been doing, including feeding, feeding persons who have been going hungry, and we cannot finish without us commending you for that particular activity. Kwa hivyo, sisi katika Wizara ya Afya tunafurahia sana vile NCCK inafanya, vile watu ambao wako private sector wanaendelea kutusaidia, ndio sisi tukiwa zote tusaidie mwananchi. Lakini mwananchi mwenyewe ni lazima pia sisi tukiwa kama wananchi, nikiwa kama Mutahi Kagwe, mimi pia ni mwananchi, ni lazima nifikirie pia ninafanya nini kujisaidia mimi mwenyewe ndio afya yangu inakuwa bora. Ninakula kitu gani? Nyumba yangu nasafisha namna gani? Yule mwingine namsaidia namna gani? Najisafisha vipi? Na sanitize vipi? Natembea wapi? Na tukiwa kama wananchi, ama hata tukiwa vijijini, tukishikana bega kwa bega, tunaona ya kwamba usafi ndio kitu ya kwanza. They say that cleanliness is second to godliness. Isn't that what we were taught? Cleanliness is second to godliness. Kwa hivyo mimi ningesihi kila mwananchi afikirie vile atasaidiana na wananchi wengine, asaidiane na serikali, ndio tuone ya kwamba ugonjwa wa aina yoyote ni kitu ambayo imeenda chini kabisa. Kwa hivyo I want to urge all of us present here today to assume responsibility for healthcare, one way or another. And I can see our GAO are here. The administrative sector is represented here. And you too, working with our religious organizations, can also help us a great deal. One of the things I would really like to urge cooperation between GAO and the faith-based is the identification of the indigent persons. The NHIF is giving, the government is paying to NHIF for 1 million people who can't afford insurance. The identification of that 1 million people that you support every year is crucial. And the person who is doing it is the county governments. But I want to urge that the county governments work with GAO, work with the faith-based people, the religious, the churches, the mosques, and so on, to identify, because this clergy, they know their flock. They know who is very poor, and they know who can afford it. Because sometimes when you ask for these lists, unapatiwa, lakini people don't know that the data bank at the NHIF is huge. We just need to put your name in the data bank. Tunaona huyo ndio kiongozi wa area fulani, ama ni sub-chief mwenyewe amejiweka list, ama ni Mutai Kagwe amejiweka hapo. You know, so this is happening. And sometimes we put in 800,000 people and we have to remove 200,000 people because we have identified them as people who are able. So let's work together to ensure that the indigent list that we are getting from the counties is genuine and properly oversighted by the community in which the lists are coming from. That way, we are able to support the poorest of Kenyans so that they are NHIF clients and they can be able to access hospitals and healthcare facilities. So that's a very important part of the work that we continue to do. So at this juncture, ladies and gentlemen, I just want to say and state that it is my pleasant duty to officially launch the AFIA NJEMA program.
I want to ask that we are all seated so that we can see the